a healthy child. And that is the reason why this topic is very, very relevant. And I welcome you all. If you have any questions, you can interrupt me in between. You can also ask me questions. So I begin with the topic, that is the diagnostic utility of the first trimester ultrasound. Now, the thing is that we all know that very basics, that the first trimester is very important. The ultrasound is very important because it can confirm an intrauterine gestation. It can know the number of fetuses, whether the cardiac activity is there or not, and even can correctly date the pregnancy. Now, if the pregnancy is less than 10 weeks of gestation, the scan is best performed transvaginally. More than 12 weeks of gestation, we start with the transabdominal scan and then we proceed with the transvaginal scan as well. Now, screening in first trimester, why is it very, very important? So it's like, again, very basics. We all know that, we have 46 number of chromosomes. Now, it is there in nature that, we cannot be born perfect. Not all individuals can be born perfect. And sometimes instead of 46 chromosome, it becomes 47. Now, these individuals who have 47 number of chromosomes, they are called as Down syndrome babies. Now, it was way back in 1990 that Langdon Down, he found that when these fetuses are there in the mother's tummy, there is an excess amount of fluid at the back of the neck, which can be seen as early as in the third month of life. And since then, we are all very, very aware that there has been a tremendous advancement in the screening for common chromosomal abnormalities. Now, why is it important to screen for trisomy 21 in particular? Actually, it is very important to screen for all the common aneuploidies. Now, the most common aneuploidies means the number of chromosomes are different as compared to the normal chromosomes. So, why is it very important? And the most common aneuploidy in nature is the trisomy 21. Why? Because these individuals have a very long lifespan. So it's not that there is a major chromosomal defect and the baby would not be able to sustain itself. The pregnancy will get terminated on its own. It doesn't happen like that. These individuals are born and they live a long lifespan. And that puts a lot of stress on the family, on the healthcare. So it is very, very important that if a female is pregnant and the baby is diagnosed to have a chromosomal problem or trisomy 21, they have to be properly counseled that yes, these are the problems that we can face when the baby is born. Now, also, it is very important to know that 70 to 80% of these Down syndrome babies are born to mothers less than 35 years of age, which means that age is a very important factor. But yes, 80% of them will be born to mothers less than 35 years of age. So the thing is that who should be screened for? Now there is a universal guidelines that screening has to be offered to all. So all pregnant women, irrespective of the age, should be offered a trisomy 21, that is Down syndrome screening. And then when should we screen? So the thing is that when the fetus is approximately, so the thing is that when the fetus is there within the mother's tummy, it's an evolving scan. So in pregnancy, how we see is that no two scans are alike. So when the fetus is 45 to 62 millimeters, that is when the fetus is very, very small. Sometimes a nasal bone might appear, sometimes we may not be able to see, sometimes it is getting formed. So the correct timing is basically when the CRL, that when the baby is approximately between 60 to 84 millimeters of length, that is 6.3 centimeters to 8.4 centimeters. It is at this period of time that we will be able to see the anatomy also. The nasal bone, if it is coming, it will, it will evolve, it will show up in the scan. And yes, it is very convenient to call the pregnant women at 12 weeks of age. So the thing is that screening for trisomy 21, as it has been known that the detection rate, if we see only as per the maternal age of the mother, the detection rate for trisomy 21 is 30%. Now, what does it mean is that long back, it was that when the mother is approximately more than 35 years of age, it started within the Europe and the UK. The trisomy 21 screening was offered to only those females. That is, the screening at that point of time was done basically by the needle testing. That you put inside the needle, you draw it fluid and send it for genetical testing. But with recent advances, we are now coming upon to screen by various modalities. And when we screen as per the ultrasound, this has a sensitivity of approximately 60 to 70%. So when I say ultrasound, what does it mean? It means that we are basically analyzing and evaluating and examining the fetus. So in the first trimester, we take the maternal age, and when we combine it with the, am I audible?
Yes, Dr. Aanchal, you are audible.
Okay, so in the first trimester, when we take the maternal age and we combine it with the nuchal translucency, so NT is the most important soft marker which is there in the first trimester. The detection rate is approximately 75 to 80%. And if we take individually, that is, we also ask the woman to get the maternal biochemistry done. Now, what is biochemistry? It is basically the blood test. Now, in the blood test, we test for the PAP-A and the beta HCG. So this is called as a double marker test. And when we combine this with the maternal age, with the nuchal translucency, and with the biochemical marker, the detection rate of trisomy 21 comes approximately 85 to 95%. And when it is combined as per the FMF, that is the Fetal Medicine Foundation protocol, that you take the other soft markers also into account, which is the nasal bone, the tricuspid flow, the ductus venosus flow, the detection rate is as good as 93 to 96% with only a false positive rate of 2.5%. So this means that a 12-week scan, that is the first trimester ultrasound, has been utilized and is also called as the NT scan. That is the most important marker is basically screened for. But now it is time that we look beyond the aneuploidies. So there are sometimes bigger and more important problems that the chromosomal abnormalities. See, so the thing is that even if the baby is chromosomally okay, if the baby is born too soon, it can lead to a long-term neonatal ICU stay, severe morbidity, or even neonatal deaths. Apart from it, there can be even deletion duplication syndromes and other karyotype abnormalities, which also need to be screened for. Apart from diagnosing the most common aneuploidies, that is the Down syndrome or the Edward or the Batau. So what is the aim of the 12-week scan? So the aim of the 12-week scan, that is the NTNB scan, it is a very, very important scan because it is in this scan that we can screen for chromosomal problems. When the baby is approximately 60 to 80 millimeters, we can even diagnose fetal structural abnormalities. We can even screen for babies that they might, there is a chance, whether there is a chance of the fetus having growth abnormalities later on. For the maternal, we can even screen for blood pressure problems, that is preeclampsia. It is also give a very important window to predict the preterm labor and also prediction and complications of in twin pregnancy. So it was basically long time back that how we used to follow the pregnancy is that at 12 weeks, a woman used to come once, we used to examine the fetus. And as the pregnancy uh, approached term, the number of a number of visits to the doctor also increased. But now it's already been 16 years, and as a Fetal Medicine Foundation, they recommended that we do a first trimester triage. That is, we screen all the females for these structural abnormalities, chromosomal abnormalities, preeclampsia, preterm labor itself at 12 weeks. We then go ahead, do an anomaly scan at 20 weeks. Finally, the delivery can take place at 37 to 41 weeks. So this is basically called as an inverted pyramid of care. That as you screen maximum at the first visit, at the 12-week scan, and the number of visits thereafter will decrease if the screening is done properly. So that means a 12-week scan is nothing but it is one-stop assessment for risk. What are we screening for? We can do an accurate dating, the anomaly scan, the blood pressure, that is a preeclampsia screening, preterm screening. For twin pregnancy, chorionicity can be screened. And also it is a good time that we do a combined first trimester screening, which obviously is a very, very important part of the 12-week scan. So, how do we screen for fetal? So, we start with number one, that is screening for the fetal aneuploidies. That is, we screen for the common chromosomal problems, and the most common, as I have already told, is the trisomy 21. So, screening for fetal aneuploidies, what is it called as a trisomy 21, the Down syndrome screening? Now, I've already explained that age is not enough. So we know that beyond 35 weeks of age, the chances of having a trisomy 21 fetus increases. But it's not that if the female is less than 35 years of age, we need not screen. As I've already said, that 70 to 80% of these Down syndrome babies will be born to women less than 35 years of age. So maternal age is one. It is only one factor which is there to screen. So the screening of the fetus should be done. So that is one maternal factor which we take into consideration. Then we screen, we examine the fetus. The examination is done when the CRL, that is the crown rump length, is between 45 to 84 millimeters. And how do we screen? We take the nuchal translucency. How we take the nuchal translucency, I will also explain. And we also take the nasal bone into the account. Apart, these are the two important soft markers. And we also take the ductus venosus and the tricuspid flows. This is the ultrasound, that is the NT-NB scan screening, in which we are looking at the four important soft markers, and we combine it with the maternal double marker test. And that's how we do it even at Artemis. We follow what is the FMF protocol. We follow what is being done all over the world to give a risk assessment of approximately 93 to 96%. So the most important soft marker which is there for the nuchal for the trisomy 21 is the nuchal translucency. Now, what is nuchal translucency? It is nothing but the aneuploidy. It is nothing but the fluid collection just behind the back. So the FMF has given very strict criteria for the measurement of nuchal translucency. And it says that the NT should only be taken when the fetus is in the neutral position. The image is magnified approximately 75% of the screen. It is in the neutral position. The sagittal section is to be taken and the NT is to be measured. The caliper placement is very, very important and it has to be on to on. NT, a wrong NT taken will definitely lead to the risk assessment, which is given in a wrong way. So the NT measurement is a most important criteria that is taken into account, and we really take care to follow the FMF protocols. So this is just one of the example that this was the cord around the neck of the fetus. Again, we can see that the fetus is in the neutral position. It is in the sagittal section and the image magnification is taken into account. The maximum measurement of the NT is to be taken. The caliper placement has to be on to on. So this was basically when there was a cord around the neck also. So in that case, the NT is taken above the cord and below the cord, and the average of the NT is taken. So what we follow in Artemis is what the world is basically following is the Estraya software. So this is the software which you can see where we put the findings of the alive fetus. The CRL is taken into account, and this is the NT. Apart from the NT, we also take the ductus venosus Dopplers, the nasal bone, and the tricuspid flows. And as we can see also that this is a very good opportunity when we can scan the fetus to look for the structural abnormalities of the brain, the head, the heart, stomach, hands, spine, and we enter everything. And finally, we get the risk assessment. Now, it is also important to analyze and to know that the NT increases with age. And that is the reason why that if we say that this is uh, 12 weeks of pregnancy and the NT is 2.3, it means nothing. We basically have to see, as the left side of the screen shows, where the NT is falling, the graph, which is very important. Now, it is very important for us to know that yes, NT is one of the most important marker for trisomy 21. The greater the NT, the greater the centiles of the NT, the greater is the chance of the fetus having trisomy 21, which is just one part of the ultrasound. But it is also, the recent research, the data has also shown that even if the NT is between 95th to 99 centile, 93% of the fetuses are going to be okay. And even if the NT, when it is between 3.5 to 4 points, so generally the cutoff that we take is 3. And what we take is not the cutoff, we see the centile. So whatever NT is taken, the measurement is charted on a graph. We see what are the centiles. Like if you see it here, we see which centiles it is falling to. And if the NT is between 95th to 99 centile, we always counsel the woman that there could be other problems associated which could be evolving. So we'll come on to that later on. But 93% this baby is going to be absolutely okay. Now above 99 centile, that is even when the NT is between 3.5 to 4.4 millimeters, 70% of these individuals are going to be absolutely healthy and normal, which means a pregnancy should never be terminated just on the findings that NT is increased and we are terminating. It should never be done. The fetus and the pregnancy, the lady should always be referred to a fetal medicine specialist for proper examination of the baby. Now, yes, it is true that whenever we have an increased NT, the fetus is to be examined very thoroughly, and there could be other causes of an increased NT. The evolving structural abnormalities could also be there. So, which means that if the NT is increased, chromosomal problems associated is number one, but there could be other problems. The fetal abnormalities could also be there associated with this increased NT. So whenever there is an increased NT, the fetus, the mother should be referred to the fetal medicine specialist. And we do a thorough scan of the fetus to screen for chromosomal problems and to screen for structural abnormalities as well. So this page basically shows the facial defects which can be there, the pulmonary defects which can be there, the gastrointestinal defects which can be there, the genitourinary and the skeletal dysplasias and other defects like body stalk anomaly and the Noonan syndrome which can be associated. So combined first trimester screening is that when we scan the fetus nicely, we look into the soft markers, that is the NT, the nasal bone, the ductus venosus, the tricuspid Doppler. We combine it with the double marker test, which is the biochemical screening, and we see what is the risk coming like. A high risk is basically when the risk is more than 1 is to 100 or 1 is more is to 150. Now, the next thing is that because these all are screening test. Screening test means that we are just wanting to know, it is not 100% diagnostic test. Like I was talking about, that the diagnostic utility could be as high as 96%, but it will never be 100%. So whenever we come across a high risk, trisomy 21 risk, which is coming high, then the next step is to do an invasive testing, which in the first trimester is called as a chorionic villus sampling. So if it is a low risk pregnancy, we continue the pregnancy and we do the normal anomaly scan at 20 weeks. So this was number one, that is we screen for fetal abnormalities. Next, this first trimester ultrasound, which is a 12-week scan, is a beautiful window when we can even diagnose for fetal abnormalities that I have already told before. So now the thing is that every scan, like the way I scan, the way it has been proposed also as per the ISUOG, that every scan is an anomaly scan. In every scan, we have to look for structural abnormalities. Those times are gone when we used to wait for the baby to become approximately 20 weeks of age and then look for structural problems. Now, many of the structural problems can very well be picked up even in the first trimester scan. So always detectable, even at the first trimester scan, are the head problems. Like sometimes the head is not formed, which is called as the anencephaly. The brain problems like lobar holoprosencephaly. The abdominal wall problem like the intestines coming out. The megacystis when the bladder is large, the absent limbs. So because when we are scanning the fetus, even as small as possible, these problems are always detectable. The undetectable abnormalities are generally the evolving abnormalities because it is the baby is still under the process of getting formed. So brain problems like microcephaly, cerebellar hypoplasia, agenesis of corpus callosum. So when the corpus callosum is not formed only, how can we know about the problems associated with the corpus callosum? So these can only be picked up when the brain is formed a little bit. That is approximately 20 to 22 weeks of gestation. Now, open spina bifida, so it said, like we are scanning, that open spina bifida, that is the neural tube defect, the hypoplastic left heart syndrome, atriovenous septal defects, renal agenesis. These are things which should always be looked carefully even in the first trimester ultrasound. So this is a fetus that is there, and if the head is not there, it is acrania, encephalocele, alobar holoprosencephaly, iniencephaly. So these are the problems associated with the head, which can very well be seen even in the first trimester ultrasound. So exomphalos, gastroschisis, very easily diagnosed in the first trimester ultrasound. Limb reduction defects, like one of the radius, that is the arm bone, is not there, or the body stock anomalies, again, can very well be diagnosed when the baby is as small as 7 to 8 centimeters. So this is basically the one of the images, one of the fetuses that I came across. As you can see that the fetus was very small, 11 weeks and 5 weeks of gestation, but this is when the baby did not have a head. So this is one of the cases of anencephaly. So next we go on. So this is the case which is one of the very rare cases that I came across. So this is when the starry gaze sign, this is again a major neural tube defect with the prevalence of one, incidence of 1 is to 50,000. And this was called as iniencephaly. And this is the 3D image which is there. So this is what you can see, that is the spine, and at the end of the spine there is a defect, and we can see the protrusions which is there. This is the open spina bifida, which was diagnosed as early as at the 13 plus 5 weeks. So this again is this thing, there is an abdominal wall defect, and we can see the contents of the abdomen herniating outside. And this is one of the cases of the skeletal dysplasias where, in the first go, it looked all normal. But when we looked closer, we can see that there is bowing of one of the bones. This is the femur bone, the bowing of the femur bones, which was diagnosed as early as in the 13 plus 3 weeks ultrasound. So this is one of the cases I came across, that there was a twin pregnancy. This was twin 2. And as you can see, the head, the neck, and the NT looks increased. But when we looked closer, I could see that there are septations just behind the head. So this was one of the cases of monosomy X, that is the Turner syndrome, which was diagnosed in the first trimester ultrasound. So trisomy 21, which is the Down syndrome, yes, very easily it can be diagnosed. And this is also one of the other cases when I came across the cystic hygroma. So this is the twin gestation, that is the conjoined twins, when it was diagnosed in the first trimester ultrasound. So once we are done with the screening of the aneuploidies, when we are done with diagnosis of the fetal abnormalities, next, which is there, is in the first trimester ultrasound, we can even screen for gestational age babies, that is FGR. And this incorporates screening for preeclampsia. So when the mother comes to us as early as in the first trimester, it is a very good period. It gives a beautiful window when we can diagnose we can give her a risk of the development of preeclampsia later on in pregnancy. See, it is at this period of time that the placental implantation is still occurring. The spiral arteries are still undergoing remodeling to incorporate more blood flows to the baby. So it is at this time that we do the screening for preeclampsia. So what we do is that we take the maternal history. I'll speak a lot about that also. I speak a small about that also. We take the blood pressure of the mother, So the blood pressure, when it is taken, it is to be taken in both the arms, and very aptly it should be taken. Next, we test for the uterine artery flows. What are uterine arteries? These are basically the arteries which are taking blood from the mother to the baby. And we combine all these things to give the female a risk of development of preeclampsia later on in pregnancy. Now, these are different guidelines, different associations, which when we are taking the maternal factors, give different maternal factors. So this was ACOG, that is American College of Obs and Gynae 2018, which had given the high risk, moderate risk factors and then given the recommendation. The NICE guidelines, that is 2019, and then it was finally the 2021, the recent ones. So the nice ones, the risk factors of preeclampsia are, as it is already given. So we always take a detailed history from the mother, asking her about which pregnancy it is, asking about the history of a hypertensive disease during previous pregnancy, any history of chronic renal disease, any history of diabetes, chronic hypertension. What is the age of the mother? Very important. What is the BMI? If there is a family history of preeclampsia, that is the mother, the female's mother, if she had preeclampsia when she was pregnant, history of multiple pregnancies. And we take all these maternal characteristics, we take the biophysical parameters, that is, we take the uterine arteries also. We also test. So whenever we are getting the double marker test, so that double marker test incorporates two things, beta HCG and PAPE. Now, PAPE tells us about the risk of aneuploidies. It also tells us about the placenta, how the placentation has occurred. And low PAPE basically means that it's a bad placenta, that the placental implantation has not occurred correctly. And when we incorporate all together, we get a risk for preeclampsia. Now, this was way back in 2019 when they wanted to see the risk of maternal, what is the association of PAPE with preeclampsia. But recently, they wanted to see what are the other chemical factors also. So as you can see here, that just when uterine artery PI is incorporated along with the maternal history, when you incorporate uterine artery PI and PAPE, the detection rate of early preeclampsia is as good as 62%. If you take a false positive rate of 5%, if you enlarge this thing, it will come out to be approximately 72%. Now, recently, it's been said that as compared to PAP-A, PLGF is a better test. PLGF is a better biochemical marker. And if you combine PLGF with mean arterial pressure with uterine artery PI, the risk of preeclampsia less than 34 weeks can be, as the detection rate can be as high as 90%. So now what we are following is that we do a complete anatomical assessment of the baby. There is something which is called as the NIPS, but because we were talking about ultrasound, I'm not going to talk about that. She's given the options whether a double marker test should be done or an NIPT can be done. And we also ask the female to get a PLGF done. So PLGF will also tell us about the placentation. Now, recently, it was the FMF that first said that there is also importance of the ophthalmic artery Doppler. This is the reason that is there. And it said that ophthalmic artery Doppler gives us a better window. So this is also another marker or another parameter which can be taken into account to screen for preeclampsia in pregnancy. Now, ophthalmic artery Doppler is of the mother. So when the female comes to us for a first trimester scan, so that is at early as in the 12 weeks, we can see what are the parameters that we are getting from the ophthalmic artery. Now, the basic is basically that as soon as a mother is developing preeclampsia, the uterine arteries are the very near which are to the placenta. But the distant arteries are also getting affected of the mother, which is the most important is the ophthalmic artery of the mother. And it's said, or it has been seen, that as the female, the risk, if the female has a high risk of development of preeclampsia, the ophthalmic artery, generally the resistance decreases. The PI of the ophthalmic artery is decreasing if the mother is going to develop preeclampsia, as to allow more blood flow into the central nervous system, and the velocity is also going to increase. So this paper basically wanted to see what is the effect of the ophthalmic artery in females who have a bladder placentation or who are at a high risk for development of preeclampsia. So this is the ophthalmic artery. This is how they measure it. And what we see is the first peaks, PSV means the first peak systolic velocity. This is the second peak systolic velocity, which is there in the image, and that is the end diastolic flow. So it's been seen that in women who are at a high risk of the development of preeclampsia, the second PSV is going to increase. And these were the various papers, the studies which were done. This is all very, very recent, in which they wanted to see what is the effect of ophthalmic artery PI when the studies are done at 19 to 23 weeks of gestation, or when they are done at 12 to 18 weeks of gestation, or when they are done at 35 to 37 weeks of gestation. And they are seeing basically, so this was the most important study, was the fourth one, that when the velocities are measured at 35 to 37 weeks of gestation, the peak systolic velocity ratio, that is the MCA PSV, this is the ophthalmic artery PSV1 and the ophthalmic artery PSV2. So if you take the ratio of second is to first, the women who are going to develop preeclampsia later on, this ratio is going to be high as compared to the normal population. So they say that whenever we are doing the first trimester scan, we have to scan for the screening of the common chromosomal abnormalities. We should also look for the structural abnormalities. We also look for the preeclampsia screening. We at Artemis are doing the ophthalmic artery Doppler on a regular basis. We are also having research going on so as to give them a risk of preeclampsia. Now, the performance of first trimester combined screening, that is a model for preeclampsia and fetal growth restriction. So the sensitivity that we give is basically preeclampsia less than 34 weeks. If we take the maternal, the mean arterial pressures, along with the uterine artery PI, along with the PLGF, and also the ophthalmic artery, the detection rate is as high as 90%. So this was again the FMF, in which it had very nicely and beautifully related what we also follow, that we do the first trimester screening at 11 to 13 weeks, and all pregnant females, we take the maternal risk factors into account, that is the history. We take the maternal mean arterial pressure, then we measure the uterine artery PI, we ask them to get the PLGF done, and we calculate the risk of preeclampsia. The risk cutoff is 1 is to 100. Now, if she falls in the high risk category, we start aspirin. Now, how much of aspirin is to be started? That is 150 milligrams per day while she is going off to bed. And then we follow the pregnancy accordingly. If she falls in the low risk category, then no aspirin is given. So this is the calculator that we use. That is the preeclampsia risk calculator. You can see that we can put everything there to get a particular risk. Then next, in the first trimester ultrasound, that is the 11 to 13 or the 14-week scan, we can even predict for preterm labor. So again and again, focusing or emphasizing on the fact that Down syndrome, chromosomal problems, deletion, duplication is one part of the problem. But there could be other things also. The baby could be absolutely healthy, but if the mother is developing hypertension, if she is going to throw a fit, then the whole pregnancy is taken for a toss. And similarly, the cervical length measurement is very, very important, and this can even be done as early as in the first trimester ultrasound. So what if there are, this thing is that we leave it, we don't do the cervical length measurement in the first trimester. So very recently, I've had patients who have come to me for an anomaly scan, and we measured the cervix and it was coming out to be 16 millimeters and 18 millimeters, putting at a very high risk of landing up into preterm labor. So the earlier we detect that there is a short cervix, the earlier we start the progesterone, or we take, if the cervix is very small, or there is a previous history of recurrent miscarriages, recurrent preterm labor, we put in a stitch. Then the risk of the female undergoing into a preterm labor, landing up into a preterm birth, is reduced. So this is how we put everything into the software, and we calculate the risk for spontaneous delivery before 34 weeks of gestation. Now, there are various papers which tells us that what is the role of what else can be done, what is the basic management whenever we come across a female who can have a preterm labor. So vaginal progesterones can be given, cervical cerclage can be done to basically avoid that. So yes, we have the risk calculator, preterm less than 34 weeks of gestation. We also look for preeclampsia, early, late, gestational hypertension. And finally, so this is basically what is the aim of inversion of ANC care, that once the female comes to you at the time, the first scan which is being done, if that scan is done properly, if the from the fetal medicine point of view, if the baby is examined properly, and even if we examine the mother properly, most of the evolving problems can be taken care of. So screening for fetal aneuploidies can be done. We diagnose structural abnormalities. We screen for FGR later on. We screen for development of preeclampsia. We predict what is the prediction of preterm delivery. And yes, if there is a twin pregnancy, we predict the complication as well. So this was the inverted of care. The more you do, the earlier you do, the better it is. So the take-home message is that the inverted pyramid of care, it's not that we let the pregnancy be. We see the woman more number of times to diagnose or to treat. So the earlier we detect, the earlier we screen, most of the problems can be taken care of. So make the most of 12 weeks, that is a window of opportunity. Now, early prediction enables risk stratification, timely referral to a specialist clinic, and time for early interventions. Thank you.
Thanks, Dr. Aanchal. Now we open to field any questions from the doctor community that is present here. Please feel free to ask your question to Dr. Aanchal directly, or you can type in the chat.
So I'm more than happy to answer any of the questions that you have.
Any questions?
Hello, doctor.
Yeah, hi. Hello.
How does the stage of CKD affect the risk of preeclampsia?
I didn't get you the risk of?
Preeclampsia.
No. What will affect the risk of preeclampsia?
CKD.
Chronic kidney disease.
Chronic kidney disease is basically if the mother is already having a kidney problem, she's already at a risk of development of chronic hypertension. And that is how, if she's already having chronic hypertension, that is, a mother is already suffering from high blood pressure. Now, whenever the placental implantation is going to take place, it is going to add over it. So, the terminology that we use is basically preeclampsia superimposed on chronic hypertension, that she is at even a higher risk of development of preeclampsia later on in the background of having a chronic renal disease or chronic hypertension, even because of other conditions like any autoimmune condition. So the risk will come high. There is more chances that the risk of development of preeclampsia will be high, which means that the risk of development of small for gestational age might also come high.
Thank you very much.
Yeah, let's look forward to more questions. Please, let's make the discussion more participative. I think this is a very relevant topic.
Yes, and it is my honor to tell you that we are using one of the most, the known softwares which is there, and we are doing everything. Whatever I have told is basically what we are following, what I am following at Artemis. So we are screening, we are scanning, and everything is being done. We try to know more and more in the first trimester ultrasound.
Dr. Jacob, do you have any questions? Dr. J.K. Wembe. Dr. Emmanuel. Dr. EPA, any questions? I mean, the French speakers, you can type the question. We will use app to translate and share with you. Okay, if there are no further questions, Dr. Aanchal, we can conclude the session. If there are any
Yes.
follow-up questions, all the doctors, they have their work group with us. They can ask and we will direct them to you. And
Yes, sure.
thanks a lot for a very detailed and informative presentation, because a pregnancy is such a hopeful yet stressful time for expecting couples, and there are so many worries, and and these detailed diagnostics can help identify any issues, and help the doctors who practice in fetal medicine to take over and do what is best for the baby and expecting mother. Thanks a lot, Dr. Achal. Thanks a lot for taking time out on a Sunday, and thanks everyone for attending this session today. We know, we who are not doctors, we know that how busy life of doctors is, and Sunday is the only time for yourself and your family. And it pleases me that every Sunday a lot of you take time out and participate in this knowledge and interactive sessions. Thank you. Thanks a lot.
Thank you so much. Namaste.